learning and the knowledge sharing should not stop. And we all uh, in our country we are seeing that a lot of doctors are sharing their views, and we are very fortunate that we have today with Dr. Ashish Kale, a very eminent IVF specialist from Pune, very known personality from all over India and internationally also. It's a it's a privilege to have you here, sir. Uh, just to say a few words about Dr. Ashish Kale, he is the founder and director and chief consultant at Asha Kiran Hospital and Asha IVF Center, Pune. He has conducted many clinical studies and has been faculty at various national and international conferences. He is ex-vice president POGS, and he was executive MCM at ISAR, MSR, and IH. It's a privilege to have you here, sir. Just a request to all the participants. If you have any questions during the session or after the session, I request you to put the question in the Q&A box, which is at the bottom of the Zoom app. And if you have any problem in audio, video, slides, you can put it in the chat. So if you have any medical questions, please, I request you to put in the Q&A, and I assure you that we will take up all the questions at the end of the sessions. Thank you so much, and over to you, Dr. Ashish.
Yeah, thank you. Thank you for that introduction. And I'm at the outset, I'm really thankful to the team of yours who make it feasible in this particular scenario. So nothing to like, we are really in the middle of a war, and we are fighting against the enemy which is not visualized to all of us. So coming down to the today's lecture, we are be talking about the stimulation protocol in IUI. Being this is what I gather, the any successful ART consultant is the successful consultant means that you know the endocrinology very well. You should be stimulating the patients without causing any side effect to the patients, like control ovarian hyperstimulations or maybe a multifetal pregnancy. You cannot make patients that untowards incidence of having NICU's admissions. Like being a ART consultant, it's not good that you should only make them a multifetal pregnancies, the patients positive with the pregnancy test, or the patients coming down to you with the triplets. It's not our aim. Our aim is to have a single fetus with a single pregnancy goes till the 9 months, 9 days. That is our aim. Our aim is not to have just a pregnancy test positive. We are now changing from pregnancy test positive to very well things that take home baby rates. So coming down to my topic of stimulation protocols in IUI, this has been already been what you call as been discussed in my group, that is the Facebook group. But still, there are many requests from my friends and my colleagues that I should be doing it again. And the opportunity given by the Samarth Pharma, I'm thankful to them also. So the why we need to do some stimulations. First of all, we need to understand to stimulation is not something that one need to just keep on doing it. It's what we need to understand is the stimulation is going to aim to have a good quality of the oocytes. We should be able to know in getting the good number of oocytes which is required for the fertilization of that oocytes. Correlation of the mild endogenous hormonal dysfunctions are there. So we need to understand, even if we are going to stimulate the patient for IUI, there are the patients which will come back to us with the hyperprolactinemia. There are the patients who will come down to us with the thyroid dysfunctions. So there are certain what you call as a subtle disturbances in the hormonal functions that has to be corrected when you're talking about stimulation for the patient. As all of us are knowing, the stimulations are required for the major category of the patients are having ovulatory disorders, and that accounts for the 18 to 25% of the infertility. So whenever you are talking about the infertility patients, it counts to the tune of 18 to 25%. So these are the patients you have to target upon, and you have to only not going to talk about the stimulation protocols for that matter, only giving a clomiphene citrate or giving a letrozole. You should be talking about a certain, that is a subtle this thing, hormonal dysfunctions like thyroid dysfunctions or maybe a prolactin dysfunctions that has to be addressed as far as the stimulation protocol is considered. I hope I am audible. Okay.
Yes, sir. Yes, sir.
So what is the effect of it? The effect of it that we should not want the discordant follicles, the follicles which is a smaller in size. We don't want one follicle is bigger and another follicle is smaller. We don't want that things to happen. We want all the follicles to increase in a size. We don't want a discrepancy into that. We don't want the stimulation effect on the endometrium, like when you are giving certain drugs that will cause the effect on the endometrium as well as on the implantation. So we are definitely clear about when you're talking about stimulation protocols. We are definitely thinking into account that the stimulation protocols are the best protocol for the patient, which will not having the effect on the endometrium, which will not have the effect on the implantation. But in the same side, we will going to have a dominant follicle, maybe a one or maybe a three follicles. So we don't want a discordant growth of the follicles. We want a uniform growth of the follicles. We don't want multifetal pregnancies. We don't want multifetal or multifetal pregnancies in order to give a NICU's admissions. So coming down to the basics of ovulatory disorders, we all of us are knowing the ovulatory disorders may be coming down to the ovulatory dysfunctions or maybe unexplained. The majority of the patients, when you talk about unexplained infertility, when you just take the detailed history of the patients, you need to invest some time in taking the histories in order to have what are her menstrual cycles, whether the menstrual cycles were regular, whether they are in irregular menstrual cycles, whether she has like a spotting in between the menstruation, whether she has that particular pain during the ovulation, or whether the menstrual cycles are irregular, whether there is a scanty flow. That has to taken into account, because whenever you are taking a good history, that will segregate the patients into two groups. The one group may be ovulatory patients, another group may be anovulatory patients. The ovulatory patients may be unexplained infertility. So the stimulation protocol for unexplained infertility may be a totally different. The stimulation protocol for anovulatory patients, where you find out there is a irregular menstruations, there is a unpredictable dates of the cycles, where your stimulation protocols are definitely a different. So coming down to the first group of anovulatory patients, where according to the WHO, we divide the groups into four groups. The first group is a hypo patients, where the both, if you do a day 2 FSH and day 2 estradiol, both of them are on the lower side. If you are doing day 2 estimations, then the second WHO group and anovulatory dysfunctions will be a normogonadotropic, normoestrogenic patients, where the FSH and the E2 may be a normal, but in subset of this group, that is a group 2 of a WHO anovulatory dysfunctions, where you will have increased LH, which is mainly a majority of the patients mainly seen in a PCOS patients group. And the third group of anovulatory patients is a hypergonadotropic anovulation, where you will see the FSH will be on a higher side. And if you do a AMH in these patients, you will have the AMH will be on a lesser side. So you have a group of group one, which is hypo, group two, a normogonadotropic, normoestrogen patients, group three, maybe hypergonadotropic anovulation, where FSH is high and your AMH is low. You have a fourth group of a WHO, which will tell you the group 4 is usually because of a hyperprolactinemic patients, where the prolactin levels, which is on a higher side. So when you're talking about an anovulatory group of patients, you need to understand, you can take the patient's history. The patients usually has the irregular periods. The patients usually have unpredictable cycles. Then you group the patients according to the day 2 hormones, whether the patient is a normoestrogenic, whether the patient is hypo, or whether the patient is hypergonadotropic anovulation, or maybe because of the prolactin dysfunctions. And the majority of the another group will remain where the patients usually have the regular menstrual cycles. They will have no obvious reasons as far as the infertility is considered. they are called as unexplained infertility. And these patients, the stimulation protocols will be different. So coming down to the what is the incidence, if you group the patients into anovulatory disorders and ovulatory disorders, in anovulatory disorders, what are the incidence? The majority of the anovulations will accounts for 40% of the PCOS, 30 to 50% are unexplained or subfertile group, which is the majority of the group. That's why I initially divided the group or divide the patients into two cycles, maybe anovulatory or maybe ovulatory patients. Ovulatory patients are 50% of the populations. They are coming into a ovulatory or unexplained infertility. 1 to 2% may have hypo, or 1 to 3% they comes into a group 3 where the AMH is less and FSH is high. So coming down to the basic things of before going into the details of any ovulation stimulation protocols, the stimulation protocols is depend upon the basic theory which is there in the ovaries. The ovary has a particular theory of two gonadotropins, two cell, two gonadotropin theory. All of us are knowing there are the two cells. The first cell is called as granulosa cells, and the another cell is a theca cell in ovaries. The granulosa cells are sensitive to the FSH and they have FSH receptors. So whichever you are giving, the FSH will act on these granulosa cells, and this is usually responsible for the recruitment of the follicle. Please have these queries or get the things are cleared, because this is the main uh, what you call as a main thing to understand about any stimulation protocol. Maybe it's IUI or maybe it is the IVF protocol. You need to understand this theory. The theory means there is the two cells are there. The first cell is the granulosa cells, which will predominantly acts on the FSH receptors are there, and the FSH will act on these granulosa cells, and these are responsible for the recruitment of the follicles that we call as an antral follicle or the choroid of the follicles. The second cell in the ovary is called as a theca cell. The theca cell has a LH receptors, and that will play a LH receptors going to have the functionality of the LH receptor is the growth of the follicle and the maturation of the follicle. So those patients who are going to have the recruitment of the follicles, these recruited follicles will later on have this LH receptors, which is responsible for this growth of the follicles and the maturation of the follicles. So these are the particular drawing which will tell you the initial there is a recruitment, and after there is a cyclic recruitment, this follicle will have the LH receptors, and these LH receptors are then responsible for the growth of the follicle and the dominance of the follicle. And that's why when you are going to stimulate the patients, you will need to have come into the mind that is called as a initial they will give a FSH, and later on they will add a LH in infertility patients or those who are going for IVF stimulation. So in IVF stimulations, where there is we are talking about POF or poor ovarian response, we usually give the HMG. Usually we add on a LH, that is a recombinant LH in later half of the cycle, because we wanted to get more dominant follicles for our maturity to attend and to get a good oocyte as far as the IVF is considered. But when you are talking about just a stimulation for IUI, we must know how the follicles are going to get recruited, how the follicles are going to get dominant, and in that factors, this particular two cell to gonadotropin theory has a role to play. Secondly, when you're talking about this particular slide, we must know what is the FSH threshold and what is the FSH window and what is the LH window. See, for all of us to just to understand the stimulation protocol, the FSH threshold is like a level. After this level, if your drug is going to hit or your level is going to increase about that threshold, the follicles will going to get recruitment is much more. So if your FSH threshold is the drug which has been given, which will once it crosses the FSH threshold, then your follicle recruitment going to get start, and the FSH window is like a longer the window. If you have broader window, you will have more follicles which is going to get recruited. You have a lesser FSH window, you have monofollicular development. This is a very basic of any stimulation protocol. So the basic of a stimulation protocol is depending upon your FSH threshold, so that your drug has to attend or has to go beyond that level to cause a recruitment of the follicle. If you wish to have a more window to get opened, or the bigger FSH window, you will land up into multifollicular development. If you have a lesser window, then you will have a single follicular development, which is going to happen. So I think up till now, I am very much clear about a two cell two gonadotropin theory. I am very much clear about what actually the window is and what is the FSH threshold. So as far as the consideration of the stimulation protocol is considered, when you are going to have a stimulation protocol for IUI, the one thing is this particular slide is going to tell you about the FSH threshold, and if the FSH threshold is not been achieved, what will happen to the rest of the follicle. The rest of the follicle is, if your FSH threshold is not received or not there, then automatically the rest of the follicle is going to have the atresia. So we'll not have co-dominant follicles, will not become mature follicles. So this is the basic thing when you're talking about any protocol, for that matter IVF, for that matter IUI is considered. Okay, so these are the particular thing when you're talking about the FSH threshold. There is called as a rescue, or there is called as a window of the FSH, and then there is a called as a downfall, where you will, if your FSH threshold is not been met, automatically these all the things are going to have atretic follicles. So we come down to the next of it, how you will decide the protocols for the patient. The decision of the protocols is not all sites fit the one. We have all the individuals are different. All our economic, what you call as a biotexture is different. We come from Asian population. Many of the friends are there from European sites. They have different mechanism because they have different AMH, they have different FSH, they have different BMI. So the any of the individuals are different. So we have different or individualist strategy for stimulation protocol. Similarly, the thing when we are talking about stimulation protocol, it has to be based upon the age of the patient, what is the basal AMH, what is antral follicle, what is the AFC. If you wish to do a stimulation protocol, you need to do a day 2 scan. The day 2 scan is important because when you're doing a day 2 scan, you need to find out is there is any residual cyst, is there is a corpus luteum which is already been there, or there is a just a simple cyst is been found out, or on a day 2 scan, what is the AFC, what is the endometrium, whether the endometrium is shedding, or what is the any other uterine pathology which has been documented. You can definitely taken care when you done a day 2 scan. So day 2 scan has its own importance, because whenever you are doing a day 2 scan, you will find out what is the AFC, what is the uterus, whether it is acutely anteverted, it is retroverted, or is there is any pathology like there is a tubo-ovarian mass, or what the endometrium is behaving. So when you are deciding the protocols for stimulation for IUI, the thing is that you have to taken care of a BMI of the patient. If the patient is obese, the same dose is not going to give you the best result. If you are going to give the same clomiphene citrate dose, which will not going to act on the patient, and you will not have the recruitment of the follicle. So the BMI also plays the important role as far as the stimulation protocol is considered. Then coming down to the something related to the AMH. What do you call as the AMH? When it is a low AMH, when it is normal AMH, when it is high AMH. The high AMH is usually seen in a polycystic ovaries. We have AMH which is more than 3.5. So in those patients, when you are doing with the stimulation protocols, you need to understand these are the patients which will going to go into over stimulation, or these are the patients which will require initial dose is on a lesser side rather than going a higher dose for those patients. So similarly, when you are talking to the normal patients, you can do a fixed dose depending upon the BMI of the patients. You can titrate the dose of gonadotropins. I'll come down to that in a little while. So coming down to the first drug, when you're talking about the clomiphene citrate, all of us are using it nationally, internationally. Maybe it's a different pathy. All of us are using the drug. The drug name is a clomiphene citrate, which is first synthesized in 1956. The commercial trial is been done in 1960. So it is not something new. It is well documented drug, well tested, it is time tested. The side effects has been documented, as far as the pregnancy and take home baby rate, as well as the abnormalities in the babies, that has already been documented as far as the clomiphene citrate is taken into account. All of us are knowing the clomiphene citrate has a estrogenic and anti-estrogenic action. 85% of the drug is eliminated within the 1 week. Why it is important to know how much is the drug is going to get accumulated inside the circulation? Because many of the time when you give a clomiphene citrate to the patient, half of the time the patient is not conceived in the same cycle and the patient is taken a gap of 1 month, you will find out the patient will come down to you a second month missed period, coming down to the pregnancy test positive. That is nothing to do with the god is there or something like that. It is the residual effect of the drug, that is the clomiphene citrate, which will be having the prolonged effect in the body. The elimination of the clomiphene citrate, it takes a longer time to drug to get eliminated. The increment of the dose is required in the obese patient. You can start the clomiphene citrate for to the tune of 50 milligram, and then you can keep on increasing the dose of a clomiphene citrate from 50 milligram. The maximum dose is 200 milligram. So after the 200 milligram, if you're not receiving the proper what you call as a growth of the follicle, or if you're not, she's not conceiving, that is called as a clomiphene failure, then you need to think in a different way what exactly strategy you need to account for. Then secondly, what is the ovulation rate? If you're giving the patient with the clomiphene citrate, it with the 50 milligram or a lower dose, if you go to the literature, you will find out that the lesser dose will be much more effective as far as the ovulation is considered. The ovulation is much more when the 50 or 100 milligram of clomiphene citrate is being used. The ovulation rate is 52%, but if you increase the dose for the same patient, your ovulation rate is going to have only to the tune of 22%. Coming down to the what ovulation, if you're not having what you call as a TVS in your hand, or maybe a LS surge in your hand, what you will do? The thing is that in those patients, you need to understand that the ovulation will going to happen after a 5 to 12 day from the last dose. So those are the other pathies which are usually given the clomiphene citrate for 5 days. They usually advocate the patient to have the intercourse after 7 days or after 5 days, seeing that, keeping in mind that the ovulation is going to happen after 5 to 12 days after the last dose. But this is not the ideal practice to be done. Ideal practice to be done is like you need to give the clomiphene citrate. You need to go for the transvaginal scan to know how the follicle is behaving, and you need to understand the color Doppler as well as the ultrasonographic role for documentation of the ovulation. Coming down to the, I will not go into the details about the receptors level of the clomiphene citrate, but just to summarize, when you're talking about the clomiphene citrate, you need to give a clomiphene citrate from 50 milligram. If there is no ovulation is documented, you can increase to the 100 milligram. If the same thing has happened, you need to increase the dose to the 150 milligram. What is the resistance? Like when you are giving the patient of a clomiphene citrate 150 milligram per day for 5 days, and she is not going to show any ovulation, that means she is resistant to the clomiphene citrate. The clomiphene failure means you are given the patient the clomiphene citrate tablets and she is going to get ovulated, but still she is not conceived. That means that she is a clomiphene failure patient. So these are the particular things when you are talking about the clomiphene citrate. So the clomiphene citrate, then there is a many of the questions will come. The clomiphene citrate, we get the thin endometrium, what will happen? See, in IUI, the thin endometrium per se has no role, because when the clomiphene citrate is given, we know the clomiphene citrate has anti-estrogenic action on the endometrium and for that matter on the cervical mucus. So whenever you are giving a clomiphene citrate, this clomiphene citrate has anti-estrogenic action, so you will have that thin endometrium. You should not be worried about the thin endometrium when you are giving a clomiphene citrate for that matter. So these are what I was talking about, the clomiphene failure and clomiphene resistance. The clomiphene resistance is usually accounts to the tune of 20%, and mainly this clomiphene resistance it can be accounted by giving additional drug, like you can add a metformin for that matter. Then you can, if that not going to solve the problem, you can always have the letrozole or gonadotropin. So I'll come down to that. I'll coming down to the how we give a clomiphene citrate as a stimulation protocol for IUI. So only the one thing about the clomiphene citrate is a multifetal pregnancies. Nowadays, being a IVF specialist or being an infertility specialist, we don't want a multifetal pregnancies, and that's why the IUI is not that much is rewarded procedure. Because if you compare the IVF procedures and multifetal pregnancies and the IUI and multifetal pregnancy, the more of the studies you will see that the IUI, when they are conceived, the chances of multifetal pregnancies is much more on a higher side. Okay. So now we'll be talking about something like a insulin resistance in PCOS. Insulin resistance in a PCOS is one of the factors that has to be taken into account when you're talking about stimulation protocol, because when you are just seeing the patient of a PCOS, and the PCOS patients, they are not some of the patients or some category of the patient which will not going to have a good results with the clomiphene citrate or resistance to the clomiphene citrate. Then in those patients you need to know certainly called as a insulin resistance, and that can be calculated by doing a HOMA index or maybe a insulin free insulin levels, or doing a certain in that particular things are. So coming down to the meta-analysis, whether the metformin should be added or whether the metformin should not be added. See, whenever you are talking about a PCOS, that is a group 2 of WHO, where you are going to have the LH on a higher side and anovulatory patients. And in those subset of the patients where there is a insulin sensitive, insulin resistance is on a higher side, in those patients, metformin is only been added to give a benefits for the pregnancy rates. But mind well, even if you see the Cochrane meta-analysis, the Cochrane meta-analysis does not support the routine advocacy of using a metformin as far as the live birth rate is considered. So coming down to the next drug, what we are going to have the next drug is aromatase inhibitor. That there is a temporary decrease in estrogen levels, which will cause increase in FSH. So there is a letrozole is usually acts as a aromatase inhibitor. This aromatase inhibitor blocks the conversion of this androgen to the estrogen, and this negative feedback will cause more secretion of the FSH. This FSH will act on the granulosa cells to stimulate the follicular growth. The studies shows that the pregnancy rates with aromatase inhibitors are similar to the clomiphene citrate. But when you are talking about the group 2 of WHO, where you will definitely see in WHO type 2 group in a PCOS, all of the literature like ISHRE or maybe ASRM, they will tell you that the drug of choice for a PCOS, the first line of treatment is a letrozole and not the clomiphene citrate. We need to understand again the FSS threshold and the window. If I'm giving the drug for a longer time, I'll make the FSH window open for a prolonged time. So there is, if I wish to have a monofollicular development, I'll give the drug of that is a letrozole for that matter, clomiphene citrate for 5 days. If I wish to open the window for a longer time, then I wish to give a extended protocol for that matter clomiphene citrate or for that matter letrozole for 10 days, same dose, a 2.5 milligram 2.5 milligram can be given for 10 days. We are increasing the length or window of the FSH. Doing that, we are going to increase the follicular recruitment, and saying that we are going to have multifollicular development. So whenever you are talking about letrozole can be given 2.5 milligram once a day for 5 days. When you're talking about a single follicular development, or whenever you're talking about multifollicular development, you can give extended protocol, or you can give a step-up protocol. The step-up protocol is like this. On day 2, you start with a 1 tablet of letrozole. On day 3, you give 2 tablets. On day 4, you give 3 tablets of letrozole. And day 5, you give 4 tablets of letrozole. And that means you are going to have a step-up of a dose. What this will cause? This will going to have a multifollicular development, because this will open up the window of the FSH and more follicles are going to get recruited. And once the dominant follicle is going to be our leading follicle in oral ovulations, I wish to give, or there are the literature which will tell you whenever you are going to give a trigger, the trigger has to be given when the size is between 20 to 22. So by this, we come to know what is exactly the points to know about as far as the letrozole is considered, because letrozole is a better drug when we are talking about side effects, because letrozole doesn't have anti-estrogenic effect on the endometrium, or for that matter will give a multifollicular development when you are doing a letrozole in a step-up protocol or extended protocol. If you are comparing a clomiphene citrate, for that matter a letrozole, definitely you will have a monofollicular development as far as the letrozole is considered. So the letrozole can be given in a clomiphene resistant patients. In those, you can definitely add up a letrozole with the gonadotropins, or maybe a purely letrozole, whichever way you can go with. So this is the something about the letrozole extended protocol. What I was talking about, you can give a letrozole to the 2.5 milligram once a day for 10 days and see whether the monofollicular development is there or not. And once the follicle is going to develop for 18 millimeter dominant follicle or more than that, you can definitely give an ovulation trigger. Then coming down to the gonadotropins, all hot topic of the gonadotropins, the dose of gonadotropin. Then we can talk about whether the gonadotropins should be given continuously or maybe interrupted, whether the HMG should be given or recombinant FSH, which is the best. So one must understand the gonadotropins in IUI has a role in a selective patients. What I mean by the selective patients, the patients already been tried on a clomiphene citrate, they are coming into anovulatory patients, or those are clomiphene citrate resistance patients, or maybe a CC failure patients, or in those patients who already we started with the letrozole, multifollicular development has already been achieved, or step-up protocols, and those patients are failed to conceive. Definitely, I will be talking about gonadotropins in those patients. Similarly, if we are going into hypo patients, that are hypo patients where the FSH is low, LH is low. So definitely in those patients, I'll be happy to start gonadotropins directly. Then I'll come down to the majority of the questions that is going to ask the gonadotropins, which gonadotropins, whether I should be using HMG, whether I should be using RFSH, or there are the preparations in the market like HP, highly purified. The dose, whether I should be started with the 75 international units, 150, 37.5, or 112. So what is the appropriate dose when as far as the gonadotropins are considered? See, these are the basic things will depending upon the dose is also depending upon, and that's why starting this lecture, I told you that you should do a day 2 scan. The day 2 scan will tell you how much are the antral follicles are there, what the follicles can be recruited in this cycle. Depending upon that, I can monitor my cycles of gonadotropins also. I can monitor my cycles with the step-up protocol of the letrozole, or maybe I can manipulate my cycles with stair-step protocol of clomiphene citrate, or BMC protocol, whatever protocol you wanted to name as. Similarly, when you're doing a day 2 scan, you will come to know what is the FC. If the FC is normal, I'll happy to go with the normal dose of maybe a 75 international units of HMG, or I will be, if the previous response is not there, majority of us are now start with 112 units of HMG, or maybe a RFSH, because nowadays we have the HMG multi-dose is also available. So definitely you can titrate the dose as far as the HMG is considered. Again, the AFCs is very much poor. I'll start with the higher dose. I'll not start with the same dose. I will start with the 150 of the HMG, or maybe a 300, depending upon the FC or depending upon the AMH of the patient. Definitely, I will not go with the higher dose, because there is always chance of OHSS, and that is difficult to manage as far as the IUI is considered. So coming down to the basic things, whether I should be using recombinant FSH or the HMG, there are the beautiful trial that is called as a megaset trial, and this is a randomized blind multicentric clinical trial which will definitely focus on the HMG and FSH, whether the HMG gives a better results or whether the recombinant FSH will give the better results in a IVF and the XC cycles in an antagonist. And what they found out, that if you go through this slide particularly with details of this particular megaset trial, they will tell you the results are as far as the HMG and the recombinant FSH is considered is at par. But when you're talking about the same things, because the megaset trial is been done in an IVF or XC patient, when you are doing this particular trial in IUI patients, the cost effectiveness is also the point to be taken into account. So I'm just giving this reference in order to know the results are not going to change, because when you are doing the trial in IVF patients, we know the quality of the oocyte, we know the fertilization, we know the how much oocytes are being retrieved. So that's why this is the one of the trial we can take as a model, or I can ideal trial to compare the drug between the HMG or FSH. So these are the trial which will tell us the FSH and the HMG has the similar success rate. There is nothing called as different success rate. What is the conclusion of this trial, of a megaset trial? In the predictive of high responders, the HMG is associated with the comparable pregnancy outcomes, and the HMG can be a given appropriate line of a treatment. Coming down to the IUI, whether the IUI is more effective as far as the IUI is considered, whether I should be adding a clomiphene citrate with the HMG, or I should just give a clomiphene citrate in an anovulatory patient. I'm talking about here a group of a patient where they are anovulatory patients, or those come in a PCO group. So definitely when you are adding a FSH to the clomiphene citrate, it favors your take-home baby rates or the pregnancy rates, which is on a higher side. So whenever you wish to have protocols which will give us a higher pregnancy rate, is the clomiphene citrate with the gonadotropins, or maybe for that matter a letrozole. They compare the clomiphene citrate with HMG as a letrozole with HMG or a FSH. The higher success rate is been documented with letrozole and gonadotropin group. So this is the particular protocol that I was talking about. Is that there are the two protocols as far as the IUI is concerned. We have a conventional protocol, and then there is a low dose protocol, a step up or step down protocol. The conventional protocol, what is the basic thing of the protocol is like, whenever you are talking about a conventional protocol, you can give a same dose for 14 days. You need to give a daily dose of injections for 14 days. After the 14 days, just do a transvaginal scan. You will come to know if the follicle is less than 10 millimeter, you can increase the dose, maybe at 25 international units or maybe at 37.5. They found out that increment by the 50% dose is better for output as far as the ovulation induction is considered, or as far as the stimulation protocol is considered. So when you are starting with the fixed protocol, what we do in our practice as far as the IUI and gonadotropin is considered, we give 112 international units of HMG or maybe a FSH for 7 days. After the 7 days, what we do, we just do a transvaginal scan. We know how much follicles is recruited. If the growth is satisfactory, what is satisfactory is the growth of the follicle is more than 10. Then after 2 days, all of us are knowing the ovulation or formation of a dominant follicle is a dynamic procedure. It has to 2 millimeter per day. So if after say 4 days, after 2 days you call the patient and the patient shows from 10 millimeter to 14 millimeter, it means that the follicle is recruited and showing the good growth. But after, if the follicle is not showing the good growth, then you can increase the dose. You can increase the dose by the 50%, or you can increase by 37.5. But in our practice, we increase the dose. What is the initial dose? Is 112, then we'll increase the half of the dose and we'll continue for 7 days and till the follicle becomes dominant. So this is something what we are doing. We are start with the starting the dose, maybe a 75 international dose for 14 days. This is a conventional protocol. And after 14 days, they do a scan. If there is no growth, increase the dose by 50%. And at the time when that single dominant follicle is 18 millimeter, you can give a recombinant SCG as a trigger, maybe a 250, or you can give a 5,000 international units of urinary SCG. Both of them are equal as far as the IUI success rate is considered. Coming down to the some of the protocols like a step down protocol. The step down protocol, what I was talking about, you can, if the follicle is, you can give a starting dose of 112.5 for 7 days. Maybe after 4 to 5 days, you just do a scan. And if you see the follicle is good growing, then you step down the dose because we don't want too much of follicles. We don't want hyperstimulation. So we step down by a 37.5 and then we decrease again after 4 days. So this is a step down protocol where you can give initial higher dose and then you can come down to the lower dose after every 4 days. So what is the best things? The another thing that usually asked me in many of the conferences or many of our group also, if we wish to give a single dose, there are multiple studies. There is called as a stimulation protocol by B.N. Chakravarti, where sir has given a HMG on day 3 and day 6. Giving HMG on day 3 of with the clomiphene citrate, thinking that when you are started with the clomiphene citrate 100 milligram, and if you are given a HMG 150 on day 3, that will increase the window and that will increase the recruitment of the follicles. The follicle cohort is going to get recruited, and when you are giving the another dose of gonadotropins on day 6, that whichever follicle is recruited can be again given the HMG on day 6. That will give a stimulation for those follicles which has already been recruited. There are different protocols as far as the clomiphene citrate and gonadotropin is considered. You can give a clomiphene citrate any day between day 2 to day 5. I'm repeating again, you can give a clomiphene citrate any period from day 2 to day 5 of your menstruation cycle day. And then after you see the response of the follicles, maybe on day 8 or day 7, if you start the clomiphene citrate from day 3, you do a scan on day 8. If you think the follicle is not growing good, you can give a single dose of HMG 150 on day 9, and still you can call the patient on day 11, see again whether the follicle is increasing or not. You can again given a one dose of gonadotropin HMG for that matter. There is another called as a pre-treatment clomiphene citrate. What is a pre-treatment? See, the pre-treatment clomiphene citrate is been advocated in those patients, especially in PCOS, thin PCOS, where you can see the endometrial lining is very less. So what you can give a non-ethisterone, like a withdrawal bleeding for 5 days. Once you stop the dose of non-ethisterone, and then you can immediately from that day, you can give a clomiphene citrate for 5 days. You can give a clomiphene citrate 100 milligram from the day you stop the non-ethisterone, and till the day patient has a bleeding, your clomiphene citrate would have been act on the follicular phase, because all of us are knowing there are the waves of the follicles. The follicles is not only in the follicular phase. The follicles can be recruited in the luteal phase also. There are the different follicular waves which comes in the single patient in the same cycle. So if you are giving a withdrawal bleeding to the patient and in the same luteal phase, if you start the same dose of a clomiphene citrate immediately after that, then definitely you will recruit the follicles and you will not have anti-estrogenic effect of the clomiphene. By that time, the endometrium is taken over. You have the beautiful endometrium which has been formed. Secondly, what you can give, you can give the gonadotropins from day 3 to day 7, that is 150 international units, and then you can see for the follicles which has been recruited Then there is another protocol where you can give HMG to the lower side. You can give the HMG 75 international units from day 3 to day 7, and then you can give a clomiphene citrate 50 milligram 3 times a day. The giving clomiphene citrate later half of the cycle is to have a prevention of a premature LS surge. So these are the novel protocol. When you are thinking of not adding antagonist to that cycle, you can give the HMG in the initial days, then you can add up the clomiphene citrate in order to have that things under control. So the prevention of the LS surge can be taken care by this protocol, giving the gonadotropins in early follicular phase, and later on you can add the clomiphene citrate in a tedious fashion or 3 times a day, or definitely you can do a addition of the antagonist. So there are the particularly when you are giving the gonadotropins maybe a 75 or 150 international units from day 2, and once the dominant follicles reaches to the 14 millimeters, that is usually what we do in IVF patients. But when you're talking about IUI, you can wait one day more also till the dominant follicles becomes 15 or maybe a 15 to 16. Then you can give a 1 dose or 2 dose maximum is required as far as the antagonist is considered. Then after the dose of antagonist has been administered, you just follow to do a follicular study. Once the dominant follicle is attained its maturity of 18 to 20 millimeters, you can start giving a trigger along with the antagonist. So this is called as the antagonist cycle of ovarian stimulation. So these are the particular RCTs of antagonist giving with the FSH IUI and FSH alone with the antagonist. They favors antagonist protocol when you are talking about the clomiphene, talking about gonadotropin stimulations in anovulatory patients. So these are the certain groups of the patient I talked about. I thought I'm talking for 1 hour now. So the part of which is remained is a part of unexplained infertility. So in unexplained infertility, everything is normal. Her menstrual cycle is normal. Her periods are normal. She's any other reason is not been documented. What is the ideal protocol? Whether I should be adding a gonadotropin will be helpful for this patient. Then the answer will come. This is just recently they advocated in the Cochrane also. These are the evidence in 2020, 1 month back. In unexplained infertility, there is no role of addition of gonadotropins. It is better that you just do a CC cycles with IUI, and in unexplained infertility, if that is working, it's better that you add a clomiphene citrate and do IUI. If that is not working, better not to add a gonadotropins into that, because addition of the gonadotropins in unexplained infertility will not helpful for the pregnancy rates, will not helpful for the ongoing pregnancy rates. It is better to shift those patients for IVF protocols. So these are the things that needs to understand as far as the stimulation protocols is considered. You need to understand what is the cost effectiveness. Anti-estrogenous appears to be cost effective as far as the IUI is considered as compared to the gonadotropins. So our first line of a treatment is to start the clomiphene citrate first. After the clomiphene citrate, if it has not been documented the good pregnancies or good ovulation, you can start with the letrozole. If you compare the letrozole and the CC with gonadotropins, letrozole with gonadotropins is a better rather than the clomiphene citrate gonadotropins. Gonadotropins can be used on daily basis or can be used in subset of the patient, can be used interruptedly like on day 9 or day 11 or maybe a day 3 and day 6. There is a beautiful presentation by B.N. Chakravarti sir, which will tell us on day 3 and day 6 importance of gonadotropin in addition to the clomiphene citrate. Or if you wish to give a continuous dose of gonadotropins, it is better to go with the low dose protocol, or because I will not advocate a conventional protocol because it's a time consuming. It takes 14 days continuous injections. Then it is depending upon tolerability of the patient. So better to go for a low dose protocol. Initially, majority of the Indian population shows a good response when you are giving 112 international units of gonadotropins. Then you can do a step up or step down depending upon the follicular response. Then you can add antagonist, but depending upon the choice of the patient. So it is always better to add an antagonist in certain patients when they have the history of premature age, or those patients, or in those patients where sorry for that particular, just a minute, I'll be back. For those patients where there is a possibility of having a premature LS surge, or those patients where you are just doing follicular studies and the follicle is vanished in the middle, then in those patients antagonist addition is helpful, but not routinely advocated antagonist protocols for IUI. It is better to give the option to the patients depending upon the previous response. You can modify your stimulation protocols. So thank you all of you that who are attending this webinar, and as far as this Facebook live also. So do if there is any queries, any questions, I'm happy to answer all of them on this platform. Thank you.
Thank you so much, sir. Thank you for taking such a wonderful session. There are a few questions from our participants. The first question is from Dr. Alwan. Uh, so they are asking, sometime during ovulation induction, they get the dominant follicle, that is 17 mm, on cycle day 8, and it happens with generally with CC or letrozole. So what to do in this case?
On cycle day 8, what they
8, day 8.
yeah.
So they get the dominant follicle on cycle day 8, and it generally happens with CC or letrozole. So what
Yeah.
to do in this case?
See, it is nothing like that. The dominant follicle will, because whenever you are talking about IVF also, the follicular phase is not the fixed one. So if you get the dominant follicle, you need to pay a little bit attention on the endometrium also. If the endometrium is too poor, then triggering this particular follicle will not venture into the pregnancies, because it's a too much higher dose what we are initiated. So in the next cycle, even if she ovulated in this cycle, in next cycle we need to tighter the dose of the clomiphene. It means that you are given the clomiphene citrate on a higher dose.
The next question is from Dr. Niranjana. How can we improve the thin endometrium?
Thin endometrium in IUI has no role as such, because if you think the endometrium which is less than 6, then definitely there is a pregnancy rate which is in the literature shows it is a lower pregnancy rate. Any endometrium above 5.6 or 6 will not label in the IUI cycle as a thin endometrium. But if you are giving a clomiphene citrate, think that it is a dose of a clomiphene citrate that is acting on the endometrium, and that is the effectiveness of that clomiphene citrate, and this effect will go eventually after the ovulation, or after this drug is going to get washed out from the body. But if you are thinking that it is a persistent thin endometrium after giving a letrozole for that matter, then you need to think about there is a causative factors like endometritis. You have to think that in that particular line of a treatment.
The next question is from Dr. Preeti. How to prepare endometrium in hypo cases and stimulation for protocol for the same?
Hypo patients, it means that you are dealing with the patients who are having a low FSH and low LH ratios. In those patients, it is definitely you need to go for IUI stimulation protocols with gonadotropins. And thinking that when you're adding a gonadotropins to the stimulation protocol, usually thin endometrium is not accountable, because HMG and this LH has an effect on the endometrium also. The endometrium will grow, but if eventually you find out the endometrium is not growing, it is better to give ethinyl estradiol or ethinyl valerate, estrogen valerate for that matter.
There is a question from Dr. Aljizani. If you find a cervical erosion while doing IUI, should we cancel it?
Cervical erosion for IUI as per se nothing to do with the success rate, because what we are doing, we are inserting the freshly prepared semen sample above the internal os. So cervical erosion per se doesn't have any effect for that matter.
Okay. Dr. Samir want to add. Dr. Samir says that you have said that to increase the FSH window and to decide the mono or multifollicular development, one has to increase the days of stimulation from 5 to 10. And he's saying, I always thought it is usually only 5 days, but it is day 2 to day 6 for monofollicular and day 5 to day 9 for multifollicular. And he wants your opinion on it.
Yeah, nice question, Samir. Basically, when you need to understand the basic theory or basic endocrinology of this particular two follicles or follicular window or FSH window and the stimulation. See, mind well, you have FSH threshold. That drug has to act and has to grow the FSH levels inside the circulation so that your follicle is recruited. You need to have a window which is morely open so that more and more FSH will act on the FSH receptor so that the multiple follicles will going to get recruited. If your window is a smaller one and you are just reaching the threshold, it means that it will act on the single recruited follicle and you will have a monofollicular development. If your window is more and your drug is above the threshold level, that threshold will act on the cord of the follicle and multifollicular development is recruited. So answering your query, whether we should give a dose from, it is a prolonged dose. We required prolonged dose rather than starting a dose of day 5. Even if you start clomiphene citrate, there is called as a step protocol. Stair-step protocol in Spirov, if you go through the Spirov, they said that if you given a clomiphene citrate for 5 days, you are not having after 5 days. See that you are started from day 2 for 5 days means that your clomiphene citrate is going to end on day 8, and after that there is no follicle is recruited. You can wait for 5 days, and after that also you can increase the dose to 100. That means that the follicular phase is a dynamic. You cannot just be dogmatic that your follicle has to have 14 days only. It is nothing like that. So it depends upon the prolongation of the cycles. It depending upon how prolonged you are giving the. That's why it is extended protocols comes into our knowledge. Extended protocol is not that we are increasing the dose. We are keeping the dose same, but for the 10 days in normal responder patients. But if you are going to the hypo patient, we increase the dose and increase the window. Okay, I hope I am clear with that particular question.
There is one more question from one doctor. He is asking, especially in mild endometriosis cases, is there any role of combining dydrogesterone along with clomiphene or letrozole?
Yeah, I think it's a beautiful question. See, the dydrogesterone come into market is for the treatment of endometriosis. So there are the many literature which will, if you go into the basic, the dydrogesterone is a beautiful drug as far as the endometriosis treatment is considered. The dydrogesterone is continuously being given, and even if you are given a dydrogesterone, they found out there is a spontaneous conception is been occurred. So there is nothing like a dydrogesterone you given and she's anovulatory. It has never happened in the in that cycle. So if there is a mild endometriosis, if you give a dydrogesterone, she is going to has her own ovulation. In the similar way, she will have the effect of the dydrogesterone on the endometriosis also. So the dual effect can be achieved by the dydrogesterone.
Dr. Vasuda want to ask, is there any particular dosage of gonadotropin or letrozole for low AMH cases?
Is the dosage of gonadotropins okay?
Or yeah.
Because on low AMH, see Vasudha, low AMH, it means that it's patients are coming down to you. Low AMH has a two. Now, if you go to another group, there are Posidian criteria. There are the group 1, group 2, group 3, and group 4. I'm not going into the detail of Posidian criteria here, but there are young patients having low AMH, older patients having a low AMH, where we know the response is low because the age is again the considering factor. In those patients, it is better that we should start with the higher gonadotropins, thinking that we know the response will be a lesser one. So in a younger patient with a low AMH, it is better to give a clomiphene citrate or letrozole with gonadotropins. But in the older patients with the same low AMH, it is always better to give a higher dose of gonadotropins directly instead of giving a letrozole or a clomiphene citrate.
Dr. Namita want to ask, this is about, I think, step-up protocol. So you have told about the step-up protocol, but she is arguing that to get the multifollicular development, wouldn't letrozole step down protocol be better than step up?
See, Namita, a step down protocol is, as far as the literature is concerned, no one has talked about. They only talked about a step up protocol. Talking about the step up protocol is one that once the FSH threshold has been achieved, if you given a dose as well as the drug on a higher side, the drug will act on the recruited follicles, and the another drug will be taken. The dose which is increased will taken up for the FSH window to get open. So that is the explanation when you are talking about multifollicular development in letrozole. Because letrozole is eventually find out to be drug for monofollicular development. It is not coming to the market for multifollicular development.
Again, another question from Dr. Namita. Would Antacro is better for a
Yeah,
multifollicular cycle?
if previous history of the patient is saying that there is a premature ALS surge, you have done the follicular study and follicle disappear during the follicular metry, then definitely those are the patients where you can think of giving a antac protocol, thinking that you can suppress the like premature ALS surge.
Uh, Dr. Momita want to ask, in IUI of unexplained infertility, can we start CC in the latter part of the follicular cycle to suppress the LH surge?
Yeah, that's what I mentioned about in my presentation. You can give a gonadotropins initially, and then you can give a chlorpheniramine 50 milligram thrice a day to prevention of LH.
Dr. Ajay want to say, is there any addition of estrogen be useful for thin endometrium? Because many people are doing that.
I didn't get the question.
Uh, there are estrogen some doctors are using for if there is a thin endometrium.
Mhm.
So, is there any role of estrogen?
See, when you're, it's depend upon which drug you are giving. If you're giving a, I'm very categorically saying it, if you're giving a chlorpheniramine, it has its mechanism of action on the endometrium. So when you're giving a chlorpheniramine and you find out it is a thin endometrium, it is not actually thin endometrium, it is a drug that makes the endometrium thin. So if you're giving letrozole and found out that there is an endometrium which is thin, then you need to think about whether the cause of a thin endometrium is because of the infective. In India, we have come across tuberculosis, which is much more commoner. We can think about what is the vascularity, what is the pattern of the endometrium. Only just the thin endometrium doesn't mean anything. It's a pattern, it's a vascularity that makes our architecture nowadays what they talked about. What is the ratio of a hypodense and hyperechoic endometrium? That as all the things taken into account.
Dr. Prachi wants please explain about dual IUI, that is pre and post ovulation, and she wants to explanation about dual trigger.
Oh, yeah. So first of all, dual or double IUI is not advocated anywhere. It is a single time IUI. The best time is to be done 42 hours after the trigger. Okay, or maybe a 36 to 42 hours. Two times you have only been done where you are getting a small volume of a semen sample, or there is a sub male factor infertility where you can try for double insemination. Now at times there is a beautiful paper in 2017 which will quote you, that is called as a subsequent pulling of the semen sample. You ask the patient to give as much as semen sample they want, then you can make a two allocates and do a double time IUI. Okay, another question was
Uh, Dual trigger.
dual trigger. Dual trigger in IUI, there is a two or three papers which will tell you giving a dual trigger. For that matter, dual trigger has to be only been, according to me, should be last resort when you are talking about gonadotropin stimulation, where you need to have, all of us are doing IVF, we know a dual trigger which will give a much more M2 oocytes. So thinking like that, if you are having a multifollicular development, you can think of giving a dual trigger, but not usual scenario, not at all.
Dr. Prakash, I think sir has explained the role of estradiol. His another question is, what is the role of sildenafil citrate?
Sildenafil citrate is a better drug when it has to be given. There are the two routes which is advocated, is a vaginal or maybe a sublingual. They come up with the strips which is dissolved in the tongue. But depending upon the vascularity of the endometrium, you need to take a call of giving uh, this particular drug. because if the vascularity is good, we are not thinking of giving sildenafil. Usually, sildenafil has to be given 25 milligram thrice a day.
Sir, many doctors are asking what is the ideal trigger dose? Is it 5,000 or 10,000 of hcg?
It is, if you are asking me theoretically, it is a 6,500 international units. But if you are talking about 5,000 and 10,000, 5,000 is better, not 10,000. And recombinant SCG is 2,500.
Dr. Vinod want to ask what is the dose of antagonist in case of premature LH search?
Okay, what's the name of the doctor? Okay. Okay, sir,
So
I was asked, there is a called as a single dose or multiple dose. Single dose 3 milligram, you can give a cetrorelix, or 0.25 daily till your mature follicles is 18 to 20 millimeters. It's a daily dose, 0.25. Or if you wanted to give a single dose, is 3 milligram.
Dr. Palul wants what are the different cement preparation techniques and where they can find the details about it.
What?
Cement preparation.
Semen, yeah, my talk was about a stimulation protocol. Semen preparation is dependent upon total motile count. If TMC is very poor or very bad sample with a high pus cells, it is better to give a density gradient. If it is a good sample, it is always a swim up method.
Okay. Sir, that was the last question from the audience.
Yeah. It's almost a 1.5 hour time.
Thank you so much, sir. Thank you so much for explaining the protocol so nicely. And I think we had taken more than around 20 questions from the participants. So it's really nice of you for answering those questions. Thank you so much on behalf of Samarth Life Sciences. And thank you all the delegates who have attended this session. Thank you so much.
Okay, thank you.
Thank you, sir.
Thank you, Ajay ji. Thanks
Thank you,
for
sir.
this particular interaction. Hope I answer all the queries what
Yes.
all my colleagues are having. It's
Yes, sir.
really nice to interact with all of you. Thank you.
Thank you, sir. Thank you so much. You give us your valuable time to us. Thank you so much, sir.
Okay. Thank you.
Have a good day, sir.
Okay, sir, we are disconnected.
Thank you, sir, from the entire Eugenic and Summer team. Thank you so much.